Okay, welcome everyone to today's noon meeting. I trust you can all hear me, and I trust you can all see my screen as well. Could somebody just indicate with a thumbs up if you're able to hear me and see my screen? Great, thank you very much. I'm Nisha Jacob. I'm a public health physician here in the Division of Public Health Medicine, and I'm standing in on behalf of Professor Leslie London today. Um, and we are very excited for today's presentation on a very topical matter. Some of you may have read a little bit about this, but we're here to hear some first-hand insights from the team. And our session today is entitled The NHI is Coming, 8 Steps to Good Governance and Leadership of South Africa's Health System. And we're very privileged to be joined by Professor Lilian Dudley, who's one of the team members who will be presenting today. And hopefully we'll get some input from some other team members during the Q&A discussion time after the presentation. So just to introduce our speaker, Professor Lilian Dudley is a South African medical doctor and public health medicine specialist. She is currently an emeritus associate professor in public health medicine at Stellenbosch University, where she was the founding director of the Center for Health Systems Development and head of Division of Health Systems and Public Health at the Faculty of Medicine and Health Sciences. Her career includes experiences as an academic, a senior public health manager, and as Chief Executive Officer of the Health Systems Trust. She's also served on the boards and advisory committees of numerous national and international public health organizations. And Professor Dudley's main research interests include approaches to improving the quality of healthcare, the quality and use of data for strengthening healthcare, and approaches to capacity development of health professionals and health leadership and management. So we really look forward to hearing your talk, Professor Dudley, and I will hand over to you.
Appreciate it. Thank you, Madam Chair. Thank you very much. We already got in at 12:10. Thank you. Thank you, colleagues.
Thank you very much, Nisha, for that introduction. And yes, I'm standing in, I believe, for Leslie London, but I hope he is on the line to pick up on the question session. So thank you very much for the opportunity. There's some background discussion happening. Is that?
Okay, I've managed to mute everyone. It's fine. Yep.
Okay. Thank you. All right. So I was part of the panel that ASIP appointed to conduct this consensus study into achieving good governance and management in the South African health system. And I'll just be going through the approach that we use very briefly, highlight some of the key results, and then talk a little bit more about the recommendations. Next slide, please. So a bit of the background. Healthcare and access to quality healthcare is one of the human rights enshrined in the South African Constitution. But looking back over the last 30 years post-democracy, even though we recognize that there have been gains in many ways, overall, there seems to be a failure to ensure the progressive realization of this right in a number of areas. We continue to have a very high burden of disease, and particularly for poverty-related diseases and other preventable diseases. Access to care has improved, but we look at very vulnerable groups, and certainly mental health care users have emerged as one of those. Access to care is still very poor. Quality of care remains a major problem in the country, and just looking at recent stats of the Office of Health Standards Compliance, less than a third of health establishments in South Africa meet our norms and standards. Equity is an ongoing issue. South Africa as a whole is one of the most inequitable countries globally, and that is also reflected in health, both in terms of health outcomes, access to health care, as well as inputs into health systems. And much of this then is reflected in our health outcomes. Even though South Africa invests more than many other middle-income countries, our health outcomes are generally poorer. So one of the questions that ASIF started asking was the extent to which governance and leadership of the health system was contributing to some of these failures that we were seeing. Next slide, please. The brief from ASEF was to determine and describe the magnitude, the spread, and the effects of the governance challenges in the health system. They wanted to identify effective strategies or best practices that could be adapted or leveraged in the South African context to address these challenges. And then thirdly, to make implementable recommendations on how to improve governance, management, and decision-making overall in the health system. ASEF has a mandate to make policy recommendations to government based on evidence. So this was really as part of their overall legislative mandate that they wanted to address these particular issues. Next slide, please. The approach that ASEF then used was to appoint a 7-member multidisciplinary panel of health system experts who undertook the study, volunteering their time and expertise. The components of the study included a literature review to firstly understand the historical context of governance in the health system, to explore different theoretical frameworks of governance which could be used to review governance within the country, and then to also identify evidence on governance interventions both locally as well as globally. The panel then held a series of consultative meetings with expert key informants who we drew from different sectors, so those representing the states, decision makers overall, service providers, as well as citizens or clients of the health system. We then followed the literature review and consultative meetings by a process of triangulating the evidence that had been obtained through those, and deliberations by the panel to reach consensus on the key challenges as well as recommendations which emerged. In addition, given the importance of the national health insurance reforms in South Africa, ASEF had asked us to look at particular issues relating to governance of the NHI. And Dr. Mark Blecher then led a team who reviewed strategic purchasing and looked at the evidence globally and also drew on expertise to identify some of the issues that needed to be addressed in governance to be able to move towards NHI. And then lastly, the report that the panel compiled was peer-reviewed, both from national as well as international experts. Next slide, please. So starting with some of the literature review, looking at the history of health systems governance in South Africa, we certainly recognize that it is plagued by, first of all, the experience of colonization, discrimination and exclusion, and certainly extensive fragmentation of governance of the health system, but then also governance of the health system, resulting in a very inequitable and fragmented system by the time democracy emerged in 1994. So post-democracy, multiple attempts have been made to address much of the challenges which were inherited. And some progress has been made. Certainly policies and programs were implemented to transform the health system in line with the white paper, to integrate and create one national health system. But as indicated, there are still many gaps that have not been adequately addressed. So as we move towards universal health coverage, we really need to look at what some of these governance challenges are that need to be addressed as we move forward to national health insurance and hopefully universal health coverage as well. Next slide, please. So looking at the literature, we felt most comfortable with the definition of governance by Van Almen, which drew on the building blocks, WHO building blocks, but spoke about governance as being one of the key building blocks which really provided overall guidance to the whole health system, provided coordination between the different actors, ensured regulation of the different roles, levels, and functions of the different actors in the system, and also ensured optimal allocation of resources with accountability from and to all stakeholders. So governance is really that mortar which holds all the other health system building blocks together and really is an overarching building block. We also took cognizance of some of the different definitions of governance within the health sector, which spoke of governance of the health system, which really focused more on what was happening in the service delivery domains, whereas governance for health speaks much more about governance of all the intersectoral and social determinants of health in order to achieve better health outcomes overall. And our brief tended to focus on governance of health, so that's really where we started, but we have tried to incorporate some aspects of governance for health, but acknowledge that we have not adequately done that, and certainly further work is needed on that. Next slide, please. Can you move the slide, Anisha?
Lilian, it's on literature on governance and leadership on my side.
Okay, so there was a delay on my side. All right, so some of the other issues that then emerged from the literature review, and we have some very good studies in South Africa and very good publications or reports as well, such as the Health Market Inquiry, the National Lancet Commission on Quality Health Systems that we were able to draw on. Overall, the evidence suggests that governance is weak, and some of the work from Lucy Gilson and others at UCT with colleagues at other universities suggests that everyday governance, so really at the front line, is weak. This is, of course, impacted by weaker governance at higher levels within the health system, but really where the patient interface is governance is a particular problem. Conflicting legislation was highlighted, so policies which actually undermine governance, for instance, the conflict in the PFMA and the PSA in terms of delegations to MECs, which conflict with some of the delegations to DGs of health in terms of whose responsibility the appointments of staff are within the provinces. So that has been a key issue for some of the provinces. Overall weaknesses in leadership and management, both at hospital levels, at primary healthcare levels, but also at very senior levels within the health system. Support systems don't necessarily enable good governance, but there's also been poor governance of support systems. And some of Helen Schneider's work here looking at human resource governance systems have highlighted some of the issues there. A number of reports have looked at oversight structures. So the MIOSI report looked at HPCSA, but other reports looking at the Nursing Council, hospital boards, have identified ways in which these very important governance structures are not actually fit for purpose and doing what they were intended to do. Community voice has been weak and inadequate. Structures for community voice have not actually provided or empowered communities to engage in governance processes in terms of informing policies or keeping health systems and health services accountable. Fraud and corruption are widely reported and are not adequately addressed within the health system. For the private sector, and here the Health Market Inquiry report was drawn on extensively by the panel, the stewardship by the national department, but also by provincial departments, has been particularly weak. We have legislation which enables government to actually address some of the governance issues, but government has not stepped up and fulfilled that role adequately. But having presented a number of critiques from the literature, there were also numerous studies which identified innovations and good practice, more so at local levels than at higher levels within the health system. And we were able to identify some international evidence of effective governance interventions from systematic reviews and other studies. Next slide, please. Okay, I'm just going to carry on speaking while my screen is waiting to change. I assume it has changed on your side. So
Yes, we're on interviews.
Okay, sorry about that. All right, so from the interviews, I'm just going to touch on some of the overarching issues which emerge and then go into some of the particular aspects. So from the interviews, overall, the complexity of governance issues within the health system were a particular challenge. And these were across the political domains, organizational complexities, and structural complexities. And, for instance, we have 4 levels within the public sector and varied political principles at each level. And these don't necessarily relate to each other. There's quite a bit of disjuncture between these levels. There's structural complexities with concurrent responsibilities and role confusion, both between levels, but between political and administrative spheres. And then we also really required to have community participation at each of these levels. And we really, I think, have been grappling with how to ensure that we do that meaningfully. In addition, we have the parallel private and public sectors, which add additional stewardship challenges. And then the health sector is very complex at an organizational level. Health organizations, I think, are one of the most complex organizations to be able to manage and lead. So, we have multiple disciplines within our institutions, referral networks, and then public-private sectors add to that even further. Financial complexities, some of the disjunctures between national setting policy agendas, but provinces actually allocating the resources between sectors and then obviously within the health sector as well. And over the last decade, we've seen in real terms the budget in health diminishing, and certainly over the last year have seen some quite severe austerity measures despite the increasing burden of disease. And then lastly, some of the complexities also relate to the nature of health being impacted by social determinants and requiring intersectoral action, which often is very, very difficult to govern. Next slide, please. Okay. So we then chose to look at some of the governance frameworks, and these you're probably very familiar with. The one that we thought was particularly useful to begin looking at governance was the Michelson-Lopez framework, which used the building blocks, but really then, as with the von Allman definition, saw governance as something which was overarching. And Michelson identified 5 key principles of governance. So really looking at strategic vision and policy design, the extent to which participation and consensus occurred within the health system, accountability, transparency, and the extent to which corruption was addressed. We also drew on more recent governance frameworks, such as those by Dudley, which looked more at the actors and the roles and the relationships between various important actors within the system. Next slide, please. So using the Michelson framework and those 5 key principles, we then analyzed the data which emerged from the interviews and the literature through the lens of these 5 principles. So starting with strategic vision and policy design, one of the key findings was that there wasn't a coherent public value mission which was shared across all the role players within the health system. Some of the policy areas where there were good intentions, but were not actually followed through with adequate implementation, was the intended decentralization within the district health system. So we have a district health system, but the delegations of authority to the district, to health institutions has actually not been implemented. And this leaves us with a very top-down decision-making system, which is also very rule-bound and hinders innovation at most levels, but particularly at lower levels in the health system. We've spoken about some of the problems in the system design and structures, such as the conflicts in delegated authorities. And this is also then translated, along with the failure to implement decentralization, with a very authoritarian, almost institutional culture, where we've neglected much of the software in terms of building trust, building relationships, and focusing on the ethics of healthcare as well. We tend to focus on what people do in terms of our monitoring and accountability, rather than what needs to be achieved. So throughout the health system, people are monitored around their activities rather than ensuring that we are achieving some of the overall goals. I've spoken about the support systems which are not designed or fit for purpose, and here some of the ones which emerged particularly were procurement systems which are not very enabling and don't prevent corruption, but also health information systems which are not really allowing us to assess some of those outcomes that we want to achieve, but also then enabling us to ensure that we are transparent and we're able to monitor adequately. Regulatory bodies have multiple weaknesses, and we've spoken about some of the health professional bodies, but also bodies like the Office of Health Standards Compliance, and are not necessarily achieving the mandate for which they were created and appointed. Also, some concepts or perceptions of lack of independence from the executive. So most of these bodies and members are appointed by the minister, but then also account to the minister. So there's no independent oversight of these bodies. And once again, as I mentioned earlier from the literature, there were successful examples, and in interviews as well, a number of the experts that we spoke to could cite some very good examples of governance, and some of them spoke about excellence in management and leadership, where there was a focus on the software in the health system, particularly at a local level, and far more collaborative approaches and peer support. So there are these examples in the health system that we really just need to elevate much more. Next slide, please. The next focus was on participation and consensus orientation. And here we looked at two aspects. The one was participation and consensus within the health system in terms of healthcare providers, particularly managers. And the other aspect was community engagement and participation. So the key issues around health managers and participants was instability of leadership, particularly at senior levels in the provinces, where there's been incredible turnover, particularly at DG level, but also at other higher levels. And this has created instability, which has impacted on governance throughout the health system. But it was also highlighted that it's incredibly challenging for people in leadership positions to actually push back against some of the political leadership. And it has come at a huge cost. And we've seen that, for instance, in the recent Tembisa hospital corruption case. But certainly, I think many other people have lost their jobs or have been demoted and have suffered when they've stood up. So these have been issues within the management and leadership sphere which have been particularly problematic. People spoke also about appointments being not based on competencies, but rather being based on other aspects. So many of our leaders and managers don't have the necessary competency and therefore unable to step up and contribute to governance. And then issues around, the software, but a lack of team leadership, which really enables shared visioning and is based on a value-driven approach to leading and managing health systems. Moving to the community aspect, even though our National Health Act provides structures for community engagement, both at hospital levels, at district levels, at facility levels, many of the policies that were intended have not been realized in practice. And there are inconsistencies across provinces because some of these processes have been delegated to provinces to establish health committees, etc. And these have really been incredible missed opportunities for engagement, for dialogue, and quoting from some of the literature, in spaces that don't infantilize or undermine the agency of communities, but which really begin to empower communities and recognize the value of the knowledge and the expertise of communities. And unfortunately, we've seen some of this carried over into the draft and to the final National Health Act, where there isn't sufficient provision made for improving the structures and for engaging with communities. And this is really one of the things that does need to be addressed. But again, there are some really fantastic examples of successes, and one that was quoted by a number of people was the Richitse project, where communities are actively monitoring the performance of the health services and other service providers around TB, HIV particularly, but also in other dimensions. And this has been rolled out and is seen as something which is holding the health services to account. Next slide, please. The next slide speaks to accountability. And we first highlight what some of the key pillars of accountability are, which firstly, we need to have very clear performance objectives. If we are going to hold people accountable, we need to know what they're being held accountable for. There has to be transparency in the process of moving towards those objectives. So we need to be able to measure, and this comes back to having an adequate health information system. We need adequate supervisory structures to be able to monitor the performance, and then there need to be sanctions or rewards for achieving or not achieving that performance. So when we look at how we've integrated accountability systems, we do have some systems. So the Auditor General does actually assess the health system, the health services at different levels. We also have the Office of Health Standards Compliance, but very often these are not functioning in the way that they are intended as well, where people are able to undermine the accountability processes, or they're not actually reporting and providing the data transparently to hold people accountable. And it's much more than financial accountability in terms of corruption. But if we are stating our objectives in terms of an overall mission and achieving better health outcomes, it's about failure to actually do that as well. The failure to appoint competent appointees actually decreases accountability within the health system and makes those appointees vulnerable to other vested interests. And then we've also seen in some of our most important accountability systems at the political level within Parliament that they have not actually held the health system to account. And the example of digital vibes came up a couple of times, where officials and politicians who were engaged in that particular problem were not ultimately held accountable. And one of the important inputs that we received was that it's not adequate just to have one accountability structure, and you, for instance, the regulatory bodies all reporting back to the minister. There need to be a range of different accountability structures. So if the one is not functioning as it should, that the others are still holding different service providers and bodies to account. And some of the examples that were also cited for failures of accountability were that we have actually had some very good reports on important issues, such as the health market inquiry, but have not actually been responded to in the ways that should have been. And also in terms of some of the ministerial advisory committees having been set up, but not actually having the teeth to address some of the issues. Next slide, please. The next slide speaks about transparency, and The two issues that we highlighted here were firstly, the lack of adequate health outcomes data for performance monitoring or contracting. And certainly as we move towards the NHI, this is going to be one of the big weaknesses as well. But transparency in appointment processes was something which many of the experts we spoke to were particularly concerned about. And there were concerns about cadre deployment and patronage networks really influencing appointments and there being a lack of transparency in that. The consequences of this were also highlighted that, again, if we don't equip the system with the right people in the right place to deal with some of these challenges, we will not be providing effective governance and leadership to the system. Next slide, please. The next slide speaks to corruption, which is the last principle, which is about preventing and addressing corruption. And the key issue here is that the system is currently not designed adequately to prevent corruption. And, we spoke about procurement systems earlier. It has become very rule-bound, but in the Tembisa scandal now, we also heard that much of the procurement is paper-based. So people can simply dispose of the evidence, and we really need to have far more electronic systems which can actually be more transparent. So also the weaknesses of some of the responses, not just the prevention side. So for instance, we saw with whistleblowers and Babita Diakaran's tragic death was really a reminder again that even where people do stand up, they are not protected. So we really need to have a system which protects whistleblowers and allows spaces for people to then speak out about corruption. The culture of the health system is a particular problem because of the sort of largely authoritarian culture. It tends to be more one of compliance and just following the rules rather than assessing and keeping people accountable on the basis of achieving outcomes. And one of the things that I think also emerged for the panel was that corruption is not just about the appointment of people who are not ethical and who are stealing from the system. It's also about appointing people who don't have the necessary competencies and therefore do not recognize corruption when it does occur and are not able to respond to it appropriately. So, the cadre deployment actually creates a greater risk of capture. One of the issues that also emerged was that in our response to corruption, we have become far more rule-bound and also punitive. And this also encourages more of a compliance culture, but that we need to have a balance. We cannot be so rule-bound and so punitive that people actually fail to take initiative then. We need to have the systems to prevent corruption, and we need to be able to monitor it effectively, but we should really be able to differentiate between where people are simply making mistakes because they're being innovative or trying to bring about improvements, and they shouldn't be punished to the extent that it's perceived the system is doing at the moment. And certainly we need to provide more effective prevention and mitigation. Next slide, please. How are we doing for time? So the next slide just highlights what the panel felt were some of the most important strategies coming out of these interviews and the literature. And overall, I think, there wasn't one key thing which needed to be addressed, but many of these factors were interlinked. And the panel felt that it was important, first of all, to get the design of the system, you get the systems right for governance, but then to get the right people in the right places in terms of appointments and competencies, but then also to empower managers as well as teams. So to also shift the culture towards being more empowering and more collaborative within the health system. Next slide, please. Then just picking up on some of the NHI issues, and this can be a completely independent talk because there was so much that came out of that review, and I would encourage you to look at that chapter. They identified some of the government issues for the NHI coming out of the Act. So the introduction of a purchase provider split, setting up the National Purchasing Authority as an NHI fund and possible branches at other levels, the changes in governance powers and functions, which the Act suggests, and particularly for district health authorities, but also provincial health departments, the move towards greater autonomy for larger hospitals as contracting institutions, and then the development of new provider payment models and moving towards a mixed provision model. These all present some additional governance challenges over and above the ones that we've spoken about already. Next slide, please. So some of the reforms that this particular chapter highlights are, first of all, the need to have stronger semi-autonomous provider institutions. So hospitals need a different legal status, and the CEO, managers, and the board need greater powers and responsibilities delegated to them with new governance, forms of new governance at those levels. The contracts, clearly, we need to be setting more objectives and clearer performance targets for institutions to form the basis of legal contracts with provider institutions. We need to be able to link the funding and performance through reimbursement reform. Our current reimbursement systems do not provide for performance-based reimbursements. Information systems, in order to have the kind of outcomes or performance measures for the reimbursements and strategic purchasing, we do need to have information systems which provide that data and support contractual monitoring. And then lastly, capacity. These are massive changes at every level, and for strategic purchasing particularly, we do need to build capacity, not just at a national level, but at every level within the health system. Next slide, please. So some of the recommendations which come out of this chapter is that we need a greater independence for the NHI fund, and we spoke about this in terms of having different oversight or accountability structures, but certainly in terms of independence from the provision side, that is the first step. The governance of the NHI fund, the composition of the board and the powers of the minister over this fund also need to be considered in greater detail. So, the issues of transparency and accountability are going to be particularly important given many of the concerns which have been emerging around the governance of this NHI fund. The powers of the different spheres of government need to be resolved and have not been adequately resolved in the Act. And these need to be far more clearly delineated, and the shifts in the functions across the spheres need to be very carefully managed. I think there's some initiatives now which are starting to kind of move functions, but it really needs a very clear plan and process. The autonomy of the institutions, I've spoken to a little bit about, but certainly that's a very important part that greater attention needs to be placed on governance. And then the procurement, ultimately, if strategic purchasing is not established as a different procurement system to the current system, we run the risk of undermining and failing the implementation of the NHI. Next slide, please. So then to summarize, just a couple of highlights in those overall principles. The key issues that came out of those was the absence of a unified public value mission, and then in terms of policy, the design of the system, the inadequate delegation of authority were key issues which impeded effective governance. Transparency and accountability, Major problems were political interference, lack of transparent processes in appointments, but also lack of information, which undermined accountability and trust in the system. Participation and consensus orientation, the limited community involvement was a major problem, as well as the top-down management approaches, which prevented decision makers lower down in the system actively engaging in decision-making. And then corruption, our system clearly needs to be tightened up, both to prevent, detect, and respond to corruption decisively. Next slide. On the brighter side, we did feel that even though these issues are very complex, there are foundations for good governance. We have structures, there are examples of good governance, but it does require attention to leadership and governance at multiple levels. And there was some urgency that we need to be addressing this now. We've been able to identify, and as we move towards the NHI, which adds additional governance risk, we need to actually begin to address it. Next slide, please. So the key recommendations, I could just skip this one, let's move to the final slide, was first of all, we need to develop a common vision, which is much more of a public mission, and in the process engage all sectors, partners and stakeholders. We need to update the legislation and governance structures to insulate them from vested interests and give them greater authority and power. Next slide. We need to delegate the authority to the different levels. We need to follow through on some of those initial intentions. We need to appoint the right people at the different levels with the right competencies. Next slide. And then support them with appropriate systems, as well as support teams within those systems to be able to build relationships and build trust and build systems. We need to authentically engage community participation, so we need to do something about the structures, but also the intention and the approach needs to be far more engaging. And finally, we need to be far more proactive about preventing and addressing the corruption and protecting whistleblowers. Final slide. So, I think some of the challenges are, the perception may be that these are huge issues and may be very difficult to implement. The panel, however, feels that they are doable, but we just need to start. Really, if there is commitment amongst the stakeholders to begin to address that, we believe that this is feasible. There was a lot of enthusiasm, and there are many people within the health system who are willing to work hard and ethically to ensure good governance. I'll end there. Thank you very much.
Thank you very much, Lilian, for a fantastic presentation, a really comprehensive overview, and I really liked the positive aspects that you brought out, and I was very reassured that there is a lot. You're getting a lot of virtual applause, that I was very reassured that there is a lot of positivity and a desire to strengthen the system and work towards bringing health for all. I see that I saw a hand just now and it seems to have disappeared. So perhaps it was also an applause. But colleagues, please feel free to raise your hand if you've got a question or pop something in the chat if you've got any questions. I have noticed that Prof. London has managed to join, and I wondered if, Prof, you had any further comments that you'd like to add while we wait for questions.
No, thanks. Sorry, I'm on my phone at UWC, so thanks, Lilian. And I don't really have much to add other than it took a long time, and at the end of the day, we're very pleased we produced something that hopefully will have impact. And I don't know if Lilian mentioned, but we do have a kind of audience with high-level policymakers in the Department of Health, so we hope the message will get through.
Fantastic. I see we have a question from, is it Jean-Marie Tucker? Or Jean-Marie? Go for it.
Hi there. Thanks. In fact, Leslie just addressed the question I was going to put there, and thank you for a fantastic presentation. It's just it's a wonderful report in terms of the breadth and the depth of issues, and also how they're interlinked. In particular, the one that stands out for me is the issue of information systems for transparency in governance. I think that's going to be very important. And it was actually in that context that I was wondering about, particularly in my area, sort of a benefits and provider payment work that we've been doing. I was interested to find out what has been the level of engagement, just given with the National Department of Health, given that I can see Mark Fletcher is on there from National Treasury, whether there's been feedback or plans to respond to this or anything like that. Thanks.
Go for it, Lilian.
Okay,
You're just on
thank you
mute.
very much, Marie, for that question. And yeah, I can't agree with you more that the information systems are actually quite key to good governance. So we do have an opportunity, I think next week, the National Minister, the MECs, DGs, and other key decision makers are having apparently a week-long retreat. And we've been asked to present this report. So that's really the first opportunity that we're having to engage at that level. But certainly we would be, looking out to follow up on that as well subsequently. So yeah, we do, recognize that this report needs to be shared, and with ASIF are working on a strategy to get it out to the right stakeholders and to try and engage actively with them. So we're hoping to get to the parliamentary portfolio committees as well at some stage, but right now very happy that we're getting to the MECs and the National Minister and DGs. I don't know if Leslie wants to add to that.
Thanks very much.
I see Nsiki's hand is up. Okay, yeah, Prof. London, did you want to add to that?
Not really to add, but we hope that the message will get through. And so thanks to Lilian for carrying it forward.
Great. Nsiki, go for it.
Thanks, Nisha, and thanks, Professor Dudley, and also extend that to the other panel members. So one of the challenges when one is looking at the status quo and the aspirations of NHI as a policy is often that there's often a gap between policymakers and the people on the ground. So I was wondering, in these conversations, I mean, I know that this is just one aspect of that. Is there capacity, to engage at lower levels, because I mean, when we talk to students, for instance, about public health, we say, everybody has a role, everybody contributes. Is there capacity, to bring in these other voices that are often not heard and people that are often not seen when we're talking about, healthcare delivery and what it should realize? Thank you.
Leslie, do you want to take the first bite at that? Feels like it's your question.
Sure. So, we want to have systems that are responsive to communities, and we want to have systems that can do what Nsiki is describing. And as you pointed out, and as the report says, we have things in place in theory, but in practice they work very differently. I think there are a lot of moving parts, and the Department of Health is going to have to prioritize, and I hope they don't put this at the back of the queue, because that's the sense I would get from past experience, that, okay, it's nice, but actually we have more important things to deal with. And at the end of the day, it's going to cost us quite a lot, because the implementation of the plans, from above will fail if they don't articulate with what people need, as you say. So, it's a work in progress, and the more people push from the bottom, the more politicians notice. I mean, it's a sad fact that our political leadership really pay attention when it's politically costly to ignore. But anyway, we can do as much as we can as academics to put it on the table, and then hope that people exhibit the leadership to see that it's important to follow through. Thanks.
Thanks, Prof. Lilian, anything to add?
Yes, thanks. Maybe I'll add. Thanks for that question, Ntiki. I mean, I was hearing that you were also asking about not just sort of communities, but other stakeholders. And one of the things that came through from some of the civil society groups and NGOs was that they felt that there wasn't the space, a space wasn't created for civil society organizations to engage with government on policy issues. So, certainly I think, and I can't speak to the intentions of government, but that is one area that does need to be improved as well. But they also then highlighted that often civil society organizations, in fact, undermine themselves by competing. So instead of collaborating and, speaking with kind of unified voices, there's far more competition, which actually weakens the efforts of civil society to engage effectively with government at different levels on policy issues. So there definitely needs to be some organization within civil society as well to actually advocate more effectively on policy issues. And obviously some groups are more empowered than others. And, one of the other things that came out was that urban-based organizations tend to have much louder voices and far greater access, whereas organizations representing or from rural areas have very, very weak voices within the system. And, that also needs to be addressed. And I mean, you were speaking about students, and certainly I think, some of the things that are emerging are that academic institutions also need to step up. And I know there are numerous partnerships between academic institutions and government, but in terms of strengthening governance and leadership, academic institutions do have a strong role to play. And maybe it's not just the students, but it's the institutions and the leaders and the senior academics who also need to be a bit more forthcoming in terms of contributing to improve governance and leadership. Thanks.
Thanks, Lilian.
Thank you.
Tinashe?
Thank you so much. My name is Tinashe. I work for the People's Health Movement. Yeah, you've touched on the issue of austerity measures, budget cuts, and so forth. How is NHI going to be possible when you are cutting the budgets? I mean, you've got billions that have been cut on education, social service, social security, and education and health as well. I don't see it really working well when instead we are cutting budget. Then my other question is that, could NHI be an opportunity for community healthcare workers to be employed permanently? Community healthcare workers are mainly women who work in townships and rural areas. They get mugged, they walk from one village to the other, they get snake bites, dog bites, and so forth. And they're still working under very, very harsh conditions. So could this be an opportunity for them to be employed as well? Then my last point is that cadre deployment itself, the way it's been happening, if I to look at the kind of MECs that we have, few of them have got few health background. Because they hold a certain position in a particular party, they become health MECs and so forth. Is this not going to hinder also NHI itself? Thank you so much.
Lilian, would you, since we've just got 5 minutes left, should we take one more question and then you can answer all together? Okay, so is it Jean-Marie or Jean-Marie? Go for it.
Thank you. It's Jean-Marie.
Great.
I had a question, just first of all, just to second the point made by Tinashe about the role of community health workers and professionalizing that scope of work. I think that's a fascinating way to go forward in that space of community-oriented primary healthcare. But I wanted to raise a point about the question of how do you get community engagement? And I think it's a valid point that there's this question of what platforms are there for different civil societies to engage. But I do think in a context where many of the elements of NHI are very technical and complex, even for the people who work in that full time. I think about, we were talking about strategic purchasing, capitation, DRGs. How do you support people, even if you have a platform, to understand and engage and learn about what these things are, so that they're not only responding to what's in the media? And in particular, one thing, just given that you were talking about the role of education bodies, I do wonder whether there isn't a role for something like the School of National Government to play a role and use their mandate to help support build that knowledge base. It's just an idea, but I'm putting it out there. Thanks.
Great. Thanks very much. Lilian, do you want to take those two?
Thanks. So starting with Tinashe's questions, look, I don't know if we can actually, as a panel, respond to the question of, do we have the financial resources to implement the NHI? Mark Fletcher may be in a better position, but I don't think that was the question that he attempted to address. I think our approach was, as we are going forward with the National Health Act now, what are the governance issues that may, in fact, prevent or which need to be addressed in order to implement the NHI. So I think the issue of finances, I unfortunately can't answer. I don't think Mark is on the line. If he is, he can please just jump in there. And we did, I think, is it Stephen Friedland giving a very different view. So I don't know if Jean-Marie also wants to pick up on that. But then the issue of community health workers, I had understood that there were already processes which were independent of the NHI to bring community health workers into the public sector. So there have been negotiations with the public sector unions and government. And I thought that there was an agreement. I probably need to go back and just follow up on that. But to address, the security of employment and conditions of service, etc. If that has stalled, then yeah, I probably just need to follow up on that. And certainly with the intention to implement community-oriented primary care as part of the health system going forward, one would anticipate that community health workers will be then officially recognized as part of the health system. It does raise new governance challenges, however, because in the past, with community health workers employed by independent NGOs or other structures, they could in fact play a role in representing the voice of the community and also holding health services accountable to communities. Now, if they are part of the health system and are reporting to facility managers, the accountability shifts to the public sector employer to some extent. And, it then raises concerns about the extent to which community health workers can actually be part of the community governance processes, and if separate measures need to be in place to ensure that they can continue to hold health services accountable to communities. And then the MECs, again, this is a big question, and maybe I'll have a better insight after we have participate in this retreat for MECs. And I think the intention with this week-long retreat is to sort of orientate some of the newer politicians to some of the issues within the health system. So hopefully by the end of that retreat, which is next week, they will be slightly better placed, but possibly there need to be some sort of ongoing initiatives. And I suppose that also then links into Jean-Marie's comment about the School of National Governance. And I think, yeah, governance is not just a health sector issue. I do think we need to be looking to some of the experts, in governance itself. And one of the panelists that we interviewed was in fact from the School of Governance, and actually gave us some really important insights into some of the failures of governance within the health sector and things that need to be put in place. So I think in terms of then engaging communities, possibly involving, other experts in governance as to the most effective ways of engaging communities, particularly around complex policy reforms, would be helpful. So yes, I think that's a valuable comment. Thanks. Leslie,
Fantastic.
Sorry.
Yeah, Prof. London has posted something in the chat. Any final words, Prof. London?
Sorry,
Okay.
no,
Yes.
I'm slowed down. So thank you very much. No final words from me. Thanks.
Okay. And I see Cheeto's just pointed, late question, intrigued by the issue of transparency, which touches access to healthcare outcomes between private and public sector. Is there ongoing engagement in this area? I think maybe Lilian, I think if you could possibly pop an answer in the chat, that would be great. But since we are officially over our time, I think we should close the session. I just want to say a very big thank you to Professor Lilian Dudley for availing herself in a very busy schedule to present this today's presentation. It was really fantastic and a really well done to the entire panel on this great work. And we hope that we wish you well as you present this to further stakeholders. And we hope that we can see the fruits of your hard work in the near future as we prepare to fully immerse ourselves in the NHI. So very big thanks, Lilian, and thank you everyone for joining and attending.
Thank you very much.
All right, bye.
Yes.
Thanks. Bye-bye.
Thank you.